Our topic today will be about hypertensive disorder in pregnancy. This wide entity disorder, we are going to explain it. We are going to talk about the sign and symptom, the pathophysiology. Then we are going to talk about the management of the hypertensive disorder in pregnancy. What is the appropriate way of measuring the blood pressure? Do you know how to measure the blood pressure appropriately? Measurement of blood pressure require appropriate size cuff, so use the size cuff suitable to your patient. You can't use one size cuff for all the size of the patient, so obese women require big size cuff. Place the cuff on the right arm at the same level as the heart, and the patient should sit for at least 10 minutes resting from walking before you measure her blood pressure to get the appropriate blood pressure. You have to notice certain things, like notice different trimester. The patients in the second trimester, usually they are going in hypotensive situation rather than in hypertensive. The patient position, the patient should be in semi-sitting position when you are measuring her blood pressure. What is the type of hypertensive disease in pregnancy? Pause for seconds and answer my question. Hypertension in pregnancy can be presented as preeclampsia, chronic hypertension, preeclampsia superimposed, chronic hypertension, or gestational hypertension. By looking to the incidence of hypertensive disease in pregnancy, you will find that 5 to 14% of pregnancy presented, they have one of the hypertensive disorder. Either it is a chronic hypertension, which is formed 3%, preeclampsia, which is formed 3 to 8%, and gestational hypertension is formed 6%. 25% of hypertensive disease in pregnancy presented as severe form, where 75% presented as mild form. What is the risk factor for the development of preeclampsia? Why it is important to know the risk factor for the development of preeclampsia? By knowing this risk factor, you are going to classify the patient into high risk group and low risk group. And if you label your patient as high-risk patient for preeclampsia, every time the patient is visiting you, you are going to look for the sign and symptom of the development of preeclampsia. And this will give you space and time to act in the appropriate time once you detect it for treatment and prevention of complication. This risk factor including nulliparity, including age more than 35 years of age and less than 18, and including family history of preeclampsia, specifically the first-degree relative, and including any chronic comorbidity like hypertension, chronic renal disease, antiphospholipid antibody syndrome or inherited thrombophilia, vascular or connective tissue disease, and diabetes mellitus, whether it's pregestational or gestational diabetes, and preeclampsia in a previous pregnancy. How preeclampsia in previous pregnancy is going to influence the current pregnancy, we are going to talk about it in a minute. So how preeclampsia in previous pregnancy is going to influence the incidence of occurrence of preeclampsia in the current pregnancy. Dr. Tital studied this risk factor, and he found that patients who have normotensive in first pregnancy or in previous pregnancy, their chance to development of preeclampsia is less than 1%, where those who have mild preeclampsia during the first pregnancy, the chance to development of preeclampsia raised to 5 to 7%, and in patients who have early detection or severe preeclampsia in the incidence of recurrence pregnancy raised to 25 to 65% to develop preeclampsia. Other factors which is increasing the risk of development of preeclampsia, including multiple fetal gestations, high body mass index more than 30%, male partner whose mother or previous partner have preeclampsia, hydrops fetalis, unexplained fetal growth restrictions, and fetal demist, prolonged inter-pregnancy interval, assisted reproduction technology, and obstetric sleep apnea. What is the definition of preeclampsia? Pause for a second and answer this question by yourself. Preeclampsia refers to a syndrome characterized by new onset of hypertension and any of diagnostic criteria for preeclampsia after 20 weeks of gestation in previously normotensive woman. It's classified either mild or severe. Now we are going to talk about the diagnostic criteria for preeclampsia in addition to high blood pressure. Pause for a second and answer the question. The American College of Obstetric Gynecology produced a clinical management guideline in January 2019, and this guideline it is the diagnostic criteria of preeclampsia, which we are going to explain it now. Diagnostic criteria for preeclampsia included: first, high blood pressure. Blood pressure should be systolic blood pressure more than 140 over diastolic, which is 90, 4 hours apart for patients more than 20 week gestation who is previously normotensive. If blood pressure more than 160 systolic over 110 diastolic, you are not going to wait for 4 hours. So once you confirm that the patient she's having high blood pressure, you remeasure the blood pressure within 5 minutes. If it is still very high, you start your medications, reducing the blood pressure and preventing the convulsion by giving the magnesium sulfate. At this time, the diagnosis will be considered with high blood pressure within minutes. You don't have to wait for 4 hours apart. So 4 hours apart for the patient who is blood pressure not exceeding 140 over 90, and it should be 4 hours apart. But if the blood pressure is high, you are going to consider her and diagnose her within minutes. In addition to high blood pressure, the presence of proteinuria. Proteinuria considered to be positive if any of the following 3 points is positive: 300 mg or more in 24-hour urine collection, dipstick reading of +2, and remember we are not using the dipstick unless it's the only quantitative method available in our hospital, protein to creatinine ratio of 0.3 mg per deciliter or more. So the question: in the absence of proteinuria, are we still consider the patients as preeclampsia? The answer will be yes. But if new onset hypertension is accompanied by any of the following criteria, which is thrombocytopenia, platelets count less than 100,000 per liter, renal insufficiency with serum creatinine concentration greater than 1.1 mg per deciliter, or doubling of the serum creatinine concentration in absence of other renal disease, impaired liver function with elevated blood concentration of liver transaminase, ALT and AST, twice the normal concentration, pulmonary edema, and new onset headache and response to medication. And remember that not accounted for by alternative diagnosis or visual symptom. So headache is mandatory to be as headache, not visual symptom, not blurred vision, not any other symptom. What is the feature to diagnose severe preeclampsia? Pause for a second and answer the question. Feature to diagnose severe preeclampsia. Severe preeclampsia is diagnosed by elevated blood pressure more than or equal to 160 over 100, thrombocytopenia with a platelet less than 100,000 per liter, elevated liver function test more than double, severe persistence upper quadrant, right upper quadrant or epigastric pain not response to medication and by excluding any other causes, renal insufficiency with serum creatinine concentration more than 1.1 or doubling of the serum creatinine concentration in absence of other renal disease, presence of pulmonary edema, new onset of headache and response to medication and not accounted for by alternative diagnosis, and visual disturbances. Pathophysiological changes in preeclampsia. What about the pathophysiology of the preeclampsia? Do you think preeclampsia is going to affect the hemoglobin hematocrit concentration? The answer will be yes. Hemoconcentration support the diagnosis of preeclampsia. What about the platelets? We said the platelets, there is a thrombocytopenia. What about the PT, APTT, and fibrinogen concentration? They are not going to be affected unless there is additional complications such as abruptio placentae or severe liver involvement or HELLP syndrome. Serum concentration of LDH. High serum concentration of LDH more than 600 international units per liter may be a sign of hemolysis and HELLP syndrome. So what about the peripheral blood smear? If there is hemolysis, then the microangiopathic hemolytic schizocytes and helmet cell will be seen. Here we could demonstrate that the first one on the right, you can see the high power view of the normal peripheral blood smear, and the one down, it is the peripheral smear for the patients with microangiopathic hemolytic anemia. You can see there is a smear showing multiple helmet cell, which is the small black arrow. The other fragment of red cell is the large black arrow. Microspherocytosis are also seen, the small blue arrow. The platelets number is reduced, and the large platelets in the center, the red arrow, suggested that the thrombocytopenia is due to the enhanced destruction. What is the changes occurring in the liver in the patients with preeclampsia? Remember that the factors involving in glomerular and hepatic injury may be similar, with vasospasm and precipitation of fibrin affecting both organs. Also, the liver, the periportal hemorrhage, ischemic lesion, and microvascular fat deposition are other histological findings observed in the liver of preeclamptic women. What is the possible symptom of liver involvement? Right upper quadrants or epigastric pain, not responding to the medication after excluding any other causes. Subcapsular hemorrhage or hepatic rupture, which may be represented also in HELLP syndrome. Elevated transaminase bilirubin in the most severe cases. So what is the changes occurring in the kidney in patients with preeclampsia? Proteinuria in preeclampsia is non-selective as a result of increased tubular permeability to most large molecular weight protein. Urinary calcium decrease because of an increased tubular reabsorption of calcium. Oliguria may occur in severe preeclampsia, and it is the consequences of intrarenal vasospasm with approximately 25% reduction in glomerular filtration rate. The uric acid concentration is increased. Hyperuricemia in preeclampsia not only because of increased production, but it's also due to increased reabsorption and decreased excretion of uric acid in the proximal renal tubules. What is the long-term maternal risk due to the preeclampsia on the kidney? Women with preeclampsia in the first pregnancy have four-fold increase in the risk of end-stage renal disease, comparing with women without preeclampsia. What is the central nervous system manifestation of preeclampsia? Patient might present with headache. Also, they might present with blurred vision and scotoma. Cortical blindness also can exist. We will talk more and elaborate more about headache because it's important and most frequent presentation for the patient. The headache, one of the most frequent complaints. The patient's coming complaining of headache, and this headache can be temporal, frontal, occipital, or diffuse headache. So the headache can be localized to the frontal, temporal, or occipit, or can be diffused. The headache characteristic can be throbbing pain, bundling pain, bursting pain. And the patient, she will tell you that she is using over-counter analgesia, like Panadol, like Brufen, but she's still having the headache and it's progressive to become severe. This headache histologically associated with hemorrhage, petechiae, vasculopathy, ischemic brain damage, and microinfarction, and fibrinoid necrosis. Other symptom the patient she might have is blindness. And this is, we call it cortical blindness, and it's typically transient. Blindness related to the retinal pathology like artery spasm or venous thrombosis, retinal detachment, optical nerve damage, and retinal artery spasm. Retinal ischemia may be permanent. What is the cardiovascular system manifestation of preeclampsia? What is the effect of preeclampsia on the heart? Pause for a second before you proceed. Try to answer this question by yourself. Preeclampsia doesn't directly affecting the myocardium, but as a response to increase the afterload, appearing to cause cardiac strain, which is reflected by four-fold increase in the concentration of natriuretic peptide in women with preeclampsia comparing to pregnant women who are normotensive or who have chronic hypertension. The question which we are going to ask, what is the long-term maternal risk on the heart and on the cardiovascular system? Is there any late sequelae for preeclampsia the woman will suffer if she had been exposed to the preeclampsia? Cardiovascular mortality later in life with estimated doubling of odds comparing with women unaffected by preeclampsia. The risk is even higher, 4 to 8 times the risk for women with normal pregnancy. In women with recurrent preeclampsia and women with early onset preeclampsia or preeclampsia requiring preterm delivery. What is this risk could be? Increase the risk of cardiovascular system complication like hypertension, myocardial infarction, congestive heart failure, cerebrovascular event, and stroke and peripheral artery disease. So what could be the pulmonary change occur in patients with preeclampsia? As the preeclampsia, it is a disease which is affecting multi-system in the body. That's why we call it syndrome. Preeclampsia affected the lung. So the etiology of pulmonary edema in preeclampsia is multifactorial. It might be due to the excessive elevations in pulmonary vascular hydrostatic pressure comparing to the plasma oncotic pressure. It can be also due to the capillary leak and due to the left heart failure, and could be iatrogenic volume overload. We already covered in the first part of the lecture the maternal complications due to the preeclampsia. As I always say that we have to think in two arms. Whenever we are exposed the patients to any disease, there will be a maternal effect as well as a fetal effect. The fetus consequences of chronic placental hypoperfusion are fetal growth restriction and oligohydramnios. The preeclampsia presented itself different with its presentation. What that means? Severe and early onset preeclampsia result in the greatest decrement in birth weights comparing to the normotensive pregnancy. And we could see that the severe preeclampsia associated with 12% of intrauterine growth restriction and early onset preeclampsia associated with 23% of intrauterine growth restriction. The same disease, if it's presented itself late, then the presentation and the effect on the fetus will be different. And these fetuses, they are associated with higher than average birth weight and possibly related to the greater placental perfusion due to elevated cardiac output and blood pressure. Is the incidence of abruptio placentae increased with preeclampsia? Abruptio placentae is infrequent, less than 1% in women with mild preeclampsia, where it's increased to 3% for patients with severe diseases. So, do we have to give antenatal corticosteroid betamethasone to promote fetal lung maturity? By looking to the evidence, we know that preeclampsia accelerated fetal lung maturity, but neonatal respiratory distress remaining common in preterm neonate of pregnancy with preeclampsia. So the recommendation, antenatal corticosteroid should be administered to women less than 34 weeks of gestation, since they are at increased risk of progressions to severe disease and preterm delivery. But remember, don't delay the delivery for the administration of full course of steroid. So what is the differential diagnosis of preeclampsia versus pre-existence hypertension, severe preeclampsia versus pre-existence hypertension, or mild preeclampsia versus gestational hypertension, or preeclampsia versus exacerbation of renal disease, acute fatty liver, thrombotic thrombocytopenia purpura, hemolytic uremic syndrome, exacerbation of SLE, gestational thrombocytopenia and autoimmune thrombocytopenia, cerebral hemorrhage, migraine, hepatitis, cholestasis, pancreatitis. Prognosis and recurrency. Patients who have early and severe preeclampsia, the risk of recurrency is 25 to 65% in the next pregnancy, where patients with mild preeclampsia in the first pregnancy, they have a risk to develop preeclampsia 5 to 7%. A patient who is normotensive in first pregnancy, their chance to develop preeclampsia is less than 1% in consequences. Going from preeclampsia to gestational hypertension, what is the definition of gestational hypertension? Pause for a minute and answer the question. Gestational hypertension is defined as systolic blood pressure more than 140 mm mercury or diastolic blood pressure more than 90 mm mercury in absence of proteinuria after 20-week gestation in previously normotensive patients. What is the risk associated with gestational hypertension? Preeclampsia will develop in 15 to 25% of women initially diagnosed with gestational hypertension. The risk correlated inversely with gestational age, so 40 to 50% high risk of progressions to preeclampsia when gestational hypertension is diagnosed at early gestational age. As you can see, the pregnancy outcome in gestational hypertension is not without risk. If it is severe gestational hypertension, early onset gestational hypertension, 25% they will develop preeclampsia. In mild gestational hypertension, 8.4% will develop preeclampsia. The sequelae of hypertension in general, gestational hypertension could be preterm delivery, small for gestational age, maternal morbidity, and abruptio placenta. So in absence of proteinuria, the patient should be managed as severe preeclampsia when elevated blood pressure accompany any of the sign and symptom of severe disease. Remember that 10% of the women with a clinical and histological manifestation of preeclampsia have no proteinuria, and 20% with women with eclampsia do not have significant proteinuria prior to the seizures. Fetal monitoring in patients with gestational hypertension. As we said, always think in two arms. You have to think about fetal monitoring, you have to think about maternal monitoring. Fetus, sign of fetal placental impairment, decreased fetal movement and vaginal bleeding and preterm labor. Ultrasound for biophysical profile, amniotic fluid estimation weekly. Estimation of the fetal weight every 2 weeks. Umbilical artery Doppler velocimetry is reserved for those fetuses with a growth restriction. And non-stress test will be weekly. So maternal monitoring, as we said, we have to keep our eye on the patient who is gestational hypertension, and the patients can be safely managed as an outpatient with weekly antepartum visits. If there is necessity for antihypertensive agent should be given. Management of a woman with a severe gestational hypertension not different from the women who have severe preeclampsia. The question is why we don't have to treat patients who is mild hypertensive. Remember that no antihypertensive agent unless hypertension is severe. Why? Because the medical therapy of mild hypertension has not been shown to improve the neonatal outcome and have the potential to mask the diagnosis of severe diseases. Severe hypertension is treated with antihypertensive agents to reduce the risk of maternal and cerebrovascular event. Prognosis of the patient with gestational hypertension. Remember that most of the women with gestational hypertension become normotensive within the first postpartum week. By definition, all should be normotensive within 12-week postpartum. The patient who is persisted to be hypertensive after 12-week postpartum, they are considered to be chronic hypertensive. And the chronic hypertensive occur in about 15% of all these cases. Gestational hypertension tend to recur with subsequent pregnancy. So now we finished talking about the preeclampsia, we talk about the gestational hypertension, and we are now going to talk about the chronic hypertension. So by definition, chronic hypertension or pre-existent hypertension is defined as systolic blood pressure more than 140/90 or both, which is present before 20 weeks of gestation, or persistent longer than 12-week postpartum. So the question always coming, if the patient's coming to you and she's not known to be pre-existent hypertension and you diagnose her at 15 week, 19 week, up to 20 week, you will consider her to be chronic hypertension, not gestational hypertension. It can be primary, essential hypertension, or secondary to any other chronic disease like renal disease, SLE, and etc. Do you think that chronic hypertension or pre-existence hypertension is important? The answer is yes. And if you want to know why, you have to know that superimposed preeclampsia occur in 10 to 25% of a chronic hypertension. Abruptio placenta occur in 0.7 to 1.5%. Preterm births less than 37 weeks occur in 12 to 34%. Fetal growth restriction occur in 8 to 16%. Other potential problems from known risk of hypertensive disease like heart failure, hypertensive encephalopathy, retinopathy, and cerebral hemorrhage. So what is the sign suggestive of existence superimposed preeclampsia on chronic hypertension? In a woman with pre-existence hypertension, development of a new onset proteinuria, and put 2 lines below new onset proteinuria. Remember when we start this lecture, we said you have to classify your patients on high risk group and low risk group. High risk group for preeclampsia, they should be thoroughly investigated in the first visit. included either 24-hour collection of protein or protein creatinine ratio, and if it is more than 0.3, then diagnosed significance. So this will be as baseline investigation is mandatory. So if the patients developed proteinuria later on, you should know that this proteinuria is existence due to the end organ dysfunction due to the chronic hypertension, or it is something new. Hypertension and proteinuria beginning prior to 20 weeks of gestation. A sudden increase in blood pressure, 160 over 110 diastolic, which is not responding to medication, thrombocytopenia, or elevated aminotransferase.